Thanks for the invitation to the 2021 International Web-Based Neurosurgical Congress. My name is Beltran, and this is the surgical management of the Craniocervical Schwannoma, a case report and literature review. The craniocervical junction is a very complex region, and it's a challenge to the neurosurgeon due to important structures nearby. This region stems from the clivus, foramen magnum, atlas, and axis. We have to take account of all the neurovascular structures nearby. Schwannomas are very common spine tumors. However, the location in the craniocervical junction is rare. The incidence in the upper cervical account for 0.1% of all schwannomas, and the surgical approaches to the craniocervical junction in a setting of this kind of tumor can be a real challenge to the neurosurgeon. It requires a careful study of the patient to make the best approach and effect a complete excision of this lesion. This is a 63 years old male right-handed patient. It had 6 months of headache located at occipital region and irradiated to the cervical net. Also, he had 3 months of progressive movement difficulties, especially for walking and taking objects from his hand bilaterally. He has no relevant disease. His Karnofsky performance status was of 60%. His motor examination revealed reduced quadriparesis, especially in hands. The strength was 3, and in lower limbs the strength was in 3 also, 3-2. The patient also had a generalized hyperreflexia, bilateral Hoffman and Trommer sign, and bilateral Babinski sign. The patient has sensory loss in the right hand and had an sphincter were concerned. Initial neuroscale was found. This is the MRI of the craniocervical junction of the patient. Showed an extraaxial lesion spanning the craniocervical junction, having a foraminal extension in the right soft tissue in dumbshell fashion. It's sized more or less that 4 by 3 centimeters, and if you can see in the right image, on the right picture, you can see how the tumor destroyed all the posterior elements of C1 and C2. So the patient went to surgery. We put the patient in the prone position. We use a continuous neuromonitoring, and we use a midline suboccipital approach to remove. After that, we performed a laminectomy of C1 and C2 to expose the extradural tumor that was depending on right C2 root. We resect that tumor, making a debulking of the mass using an ultrasonic aspirator. Due to the compromise of the C1 and C2 posterior elements showed in the CT, in the pre-op CT, we need to make an occipital cervical C3 and C4 arthrodesis fixation using a translateral mass screw technique to make this fixation, as you can see in the right picture. The patient has no neurovascular complication during the surgery. There was no complication registered in the neuromonitoring, and the patient had a fully recovery during the postoperative period without surgery-related complications. He recovered strength within a few months and was able to walk again with a Neuri grade of 2. Pathology confirmed the diagnosis of schwannoma. And if you can see here in the right picture, you can see the postoperative X-ray. The spinal schwannoma, also called neuromemoma, are benign tumors of the peripheral nerve sheath. These tumors are one of the most common extramedullary spinal tumors, but schwannomas involving craniocervical junction are uncommon. Calvacanti, for example, reported only 13 cases in his 20 years course. Also, Lenzi documented 19 patients with craniocervical schwannoma in his nearly 370 patient study. According to Schroeder, we can classify this tumor as giant schwannomas. This is due to compromise because this tumor compromised 2 or more vertebral segments, and the tumor size of the extraspinal component was more than 2.5 centimeters. All of these symptoms was result from the spinal cord compression and erosion of the posterior elements of C1 and C2 that we showed previously. The neuric gradient score is an important tool also to assess the patient with myelopathy and has a good correlation and follow-up once the surgery is done. There's a study that shows that greater preparative neuric grade and symptoms lasted more than 12 months have lower odds of improvement after decompressive surgery. We can advocate for early decompressive surgery in patients with cervical myelopathy. The surgical removal is the treatment of choice of this tumor, and we have to make a careful planning to perform this resection. We have to know that there is neurovascular structures that involve all the craniocervical junction, and the surgeon must evaluate the necessity of stabilization of the segments of the affected segments by extension of the tumor compromise. We have to consider all the approaches to make the best resection of this tumor. You have to use lateral approach, midline suboccipital approach, anterior approach, etc. But in this case, we use the suboccipital approach because all the tumor was dorsally and all the posterior elements of C1 and C2 were destroyed. So this approach allowed us to remove all the tumor and stabilize the craniocervical junction. The surgical treatment of these craniocervical schwannomas is a formidable challenge due to his complex location. Knowing and mastering all the anatomy of this region, knowing the neurovascular structure around this area, knowing the biomechanical features, leads to the neurosurgeon to make the best resection without the most terrible complication of these lesions. Also, it is necessary to individualize each case for make an optimal result of all these lesions. Thank you, everyone, and thank you for the invitation.